This is what our future is going to look like according to their own projections. This is from the government. So they are saying physician spending per enrollee is going to decrease. Medicare economic index is not going to decrease. So that means our expenses are going to go up. Our updates are going to be lower. There is no increase for physicians, but expenses are going to increase. And we are not coming up with these statistics. They are coming up with them, their own numbers. All in all, we are doing better than a lot of other specialties. That is because we were able to get our practice expense increased originally from 1976. So later on to $59 per hour to $156 if you are enrolled as an interventional pain physician. If you are a pain medicine, this is all. But all these are calculated as averages. It is not by your own designation. You don't get paid based on your own designation, but this goes into calculations based on how many people are enrolled as so-and-so specialty. Well, we are doing a little bit better on lots of things. Look at the malpractice suits. For 100 physicians, there were 350 lawsuits for neurosurgery. Neurology, 110. Anesthesiology, 67. Physical medicine rehabilitation, 35. That is the lowest one. Internal medicine, 59. Pain medicine, 113. Pain medicine, that means not interventional techniques. But we are at 57. So there are a few good things about interventional pain management. Now, how are our payments? 2011, they were not going to cut our payments until December 29th. We got the Christmas present on our end of year present, 29th. So with the cuts compared to 2006, we are going to get increases even with the cuts, okay? That is because of the practice expenses and a lot of work. Whereas in office setting, the cuts are going to be lower. You still see big cuts, but these are all for add-on codes. Add-on codes, they are trying to remove them completely. Without cuts, we would have been much better here. Again, compared to 2010, we are better off in 2011. You may not believe it, but that's true. Now, if you are working in an office setting, we have improved those payments significantly. Now, for an epidural, you get 113. Last year, it was 101. For a facet joint, it was 58. Now it is 81. For radiofrequency, it is higher. But in a hospital setting or ASC, they misvalued some of the codes. We have been trying to explain to CMS. They don't understand anything. It is so hard. The Congress, members of the Congress, we went to them and we called from Ed Whitfield's office, and they were so confused. CMS was trying to explain to me what to do. I finally told I'm the one who started this classification. I got it approved before. Oh, okay. So hospital payments are pretty good. Unfortunately or fortunately, I'm the one who tried to get this classification. I'm the one who did it, but that's good though. Hospitals do well, we do well too. Just remember that. Let us not trash the hospitals. With regards to the board certification, we have ABMS. They are not giving any new boards. There is no new board since 1991. So we are going to try, but this will be a really uphill battle. Programs, there are 93 accredited programs for fellowship. ABIP. This is the one we are trying to introduce. Now, we don't know what will happen. You have to pass a written examination or ABMS pain medicine plus controlled substance and practice management. Technical competency, this is a different examination. You have to take it separately. If you are FIP, if you qualified and approved by December 31st, that's fine. Otherwise, please don't ask me anymore. And this is Part 1 curriculum, questions, anatomy, physiology, pharmacology, psychology, everything. The only difference from ABPM is that we have more on interventional techniques, coding compliance, and controlled substance. In ABMS board examination, you really don't have that many questions on interventional pain management. On part 2, these are the 19 procedures we will be examining. You will get 4 procedures, I think, 4 or 5. So you have to demonstrate your competency. These are the commonly used procedures. These constitute 92% of the interventional pain management. This is the term sheet. They will be asking our scoring sheet. There will be different modules on the diagnosis, treatment module, and complications. If you are taking the exam, they will be discussing more with you today. And this is the practical examination scoring sheet. Patient positioning, C-arm positioning, needle placement, also includes what type of needle you use. Drug administration and interpretation of fluoroscopic images, and if you committed any fatal errors. Like if you put the needle in the spinal cord, didn't know it, I think that's done, at least for this time. So, if you do not have a fellowship training, then you can go through an alternate path. It is 6 years of full-time teaching, 300 hours of teaching or practice, 300 hours of continuing education, and unrestricted license. We do have some traction now. In 8 states, you really don't have any regulations about saying board certified. Those are the 8 states. In 11 states, state Medicare medical boards have approved ASIPP as equivalent to ABMS board. And in multiple states, we are pending. So our future depends on our own philosophy and ownership, research, and lobbying. Now, there are lots of people who can complain. It is easy to complain. I get so many letters. Sometimes I get sick of this. I want to resign. I don't want to be there any longer. But then I remember this quote. I have a poster in my office. A critic enjoys a tremendous advantage if he has done nothing himself. So, we have done lots of things in 12, 13 years, and everybody was laughing at me before. Now they are jealous. Things happen. We have IPM as a seat on the CAC, Pain Physician Journal. We have done a lot of legislative achievements, AMA membership, which doesn't mean that much, but it works on CPT and ICD, the RUC committees. Specialty designation, reimbursement issues, board certifications, guidelines, education, and public relations. So this is how future works for you. Ownership philosophy, that means you build it and you own it. Ownership is you are going to rent or lease. Receivership, this is how entire America is going to be pretty soon, like European philosophy, government housing and entitlement philosophy. Like Ronald Reagan used to say, there is no limit to what a man can do or where he can go if he doesn't mind who gets the credit. That applies to women too, but in a ownership philosophy, you don't apply that. You are going to look for your own personal glory and renegade mentality. That means you are the only person, me, myself, and I kind of thing. In a receivership, you think they owe it to you. Like Sam Rayburn said, any jackass can kick down a barn, but it takes a good carpenter to build one. That is what in your ownership philosophy you think. In ownership, you're going to stay quiet. When things are done, if it works in your favor, go ahead and take credit. In receivership, it is even worse. First, you are going to oppose it and criticize it. When it is all done, you take the credit. JFK, that is what he said about society. Ask not what your country can do for you, ask what you can do for your country. I'm a very bipartisan person, so I use all of this. In a ownership, there are only 3 important people in your life. That is me, myself, and I. This is a highly effective mode, is the ownership. It may be risky, but it is highly effective. Ownership is somewhat effective, and receivership is extremely ineffective. So let us get over this motivational deficiency syndrome, be proactive, accountable, and ethical. Come to Washington, very nice place. You should visit sometime. How many of you have visited Washington so far? Okay, so you like it, right? Don't you love it? Meet legislators. It is good to know. They don't understand anything. You have to sit down and explain to them. And whenever it is possible, contribute through ASIPP. Your office is Lobby Central. You are a pretty powerful person, actually, if you really want to work at it. Research and publish. Just remember, when you join all these societies, it is going to cost you a lot of money. Other day, I got a newsletter from NAS. I have not been a member of NAS for 10 years. They are still sending me newsletters. It is $550. I don't know why I want to be a member of NAS. So they are always trying to hurt us in every aspect. Only thing I know is how to oppose them, not to. So newsletters cost a lot of money. All in all, you will be spending $10,000 or more to just working with them, and you can get all the same information for $450 from ASIPP. ASIPP Foundation, we don't have much traction. ASIPP for high quality IPM, where we work on non-qualified practitioners doing interventional pain management like nurse anesthetists or other practitioners. We have residence fellow section, which is very active. Believe it or not, we have an AMA delegate membership for residents. So this is our pack. You can join become a Capital Club member at any level, but join and at some level try to become a member. It is very important. So these dollars do talk. When we talk to people, they only talk to you, or their staff will talk to you if you don't have anything, if you are there in district. But if you really contribute well and everything, they will really sit down and talk to you. Now we take credit cards. Just remember, man spends his life in reasoning on the past, in complaining of the present, in fearing the future. We need to get out of this. Thank you.